Welcome to section 35 on the Falcon Physician Reviews Online Anatomy section. This time we're going to discuss the development of the internal genitalia. They're going to be starting after the craniocaudal folding, and of course they're already determined genetically, but now we need to go through an indifferent gonad stage. In the indifferent stage, the testis and ovary will both be developing from the genital or gonadal ridge. That's started to appear in the medial mesonephros region, and it's covered with mesothelium. By the 6th week, the coelomic mesothelium has proliferated and grows into underlining mesenchyme to form the primary sex cords. The primordial germ cells have migrated from the yolk sac, as we saw in the last segment, and they're going to become the primary sex cords, or migrate into them. In the indifferent gonad, at this stage, the cortex and the medulla exist, but in the female, the medulla is going to regress, and in the male, the cortex will regress. In the indifferent stage, around the 5th week of embryogenesis, there's going to be an activation of the Y region, which is known as the SRY, or the sex-determining region of Y, and that's going to have a testis-determining factor, which will be released at stage 7. If that testis-determining factor is not there, either through inactivation on the Y that exists, or through the absence of a Y, there's going to be the default pathway, which does not require genomic materials to go, and that's going to start along the female developmental path at around 12 weeks. So to become a male, you get a couple weeks head start. There's going to be an aggregation of the neural crest cells on the dorsal aspect of the embryo, and then the intraembryonic coelom, and along the edge of that you're going to have the indifferent gonad developing around the T10 dermatomal region. If we look closer at this gonadal ridge, the germ cells have migrated in to make the primary sex cords, and then there's going to be the development of either the cortex or medulla, depending on if it's male or female. Remember, this is going to use the mesonephric duct if it's male, or this will degenerate if it's going to become a female. Let's ask some questions. A female enters your practice complaining of a swollen region just inside the vaginal canal, which causes pain during coitus. You're diagnosing her problem as a Gartner's cyst, which you know is the persistent remnant of what structure? Even though we haven't completed this component yet, hopefully that last introduction where we've talked about the fact that the mesonephric duct will be used in a male but not used in a female would suggest that that mesonephric duct will have some remnants that could cause things such as Gartner's cyst. Now we'll move on to this bipotent gonad. This schematic will show that the gonad forming in the midline is going to be using certain components, and then it'll be dropping off other components whether it develops as male or female. In the male, they'll maintain the mesonephric duct and the tubules, which will be components of the gonad itself. In the female, they will develop a paramesonephric duct in the absence of the testis-determining factor and some of the hormones that will be released as a result of downstream events that occur because of that genome. Now, if you look at the differentiation a little bit later, you can see that the mesonephric duct in the male will give rise to the ampulla, the vas deferens, the epididymis, as well as the seminal vesicle and the ejaculatory ducts. But you can see a small remnant on the testis known as the testis appendices, and that's going to be a remnant of the paramesonephric duct. In the female, the mesonephric duct all but degenerates in a few places, which could leave the remnants lead to a Gartner's cyst. And the paramesonephric duct are stimulated to develop. They will give rise to the fallopian tube, the uterus, and most of the vagina. Let's concentrate on the female genital tract. In the presence of ovaries and the ovarian hormones, there's going to be the Mullerian system starting to develop. Mullerian is going to be German, which is similar to the root word mother. And then in the male, there's going to be degeneration of that system, or no formation of it, because it's going to be inhibited, and the Wolffian duct will form. But the Wolffian duct, also known as the mesonephric duct, degenerates in the female. The cranial components of the mesonephric duct will form the fallopian tube. The more caudal portions of the duct should fuse together and form the uterovaginal canal, and that will open up into the urogenital sinus. The paramesonephric ducts will carry them with them a layer of mesenchyme, which is going to stretch across the pelvis and form the broad ligament. So as those paramesonephric ducts move towards the midline, they'll pull that peritoneum with them, forming the broad ligament as it fuses around and together. The uterovaginal canal is going to form the lining epithelium of the uterus and the cervix, and the endometrial stroma and myometrium will develop from the surrounding splanchnic mesoderm. Remember, we talked earlier about the splanchnic mesoderm and how it forms the visceral smooth muscle. There's going to be a pair of endodermal outgrowths known as the sinuvaginal bulbs, and those are going to arise from the urogenital sinus as it gets separated off. The uterovaginal canal will then connect to that. That sinuvaginal bulb will unite and form what's called the vaginal plate. And it's that central portion of the plate which should degenerate and form the lumen of the vagina. If the lower portion of that is still in place, it forms a hymen. In some places it will not stay in place and there'll be no hymen. Let's look at what becomes what. We have the urogenital sinus from the primitive urinary tract. We have a mesonephric duct, which is going to essentially degenerate, and we have the paramesonephric duct. The paramesonephric duct will fuse towards its caudal end and form the uterus, and will stay dissociated in its cranial end and form the uterine tubes. Down at the sinuvaginal bulb, there's going to be the portion that degenerates, forming the hymen, and that will open up into the vestibule where the labia minora are starting to form. Now, if there's any remnants that remain from the mesonephric system, it could form either a paraoophoron, which could be cystic near the ovary, or it could have a Gartner's duct, which could be attractive tissue running along the side walls of the uterus. That's something that you may be keyed into, of a cystic or duct-like structure running along the lateral sides of the uterus. Or there may be a cyst at the level of the cervix, just outside of the cervical region, which would impinge upon either the vaginal wall or the cervical wall. Those will be the Gardner's cyst. Now, as we think about uterine malformations, the paramesonephric ducts, if they don't come together properly, will obviously have malformations to the uterus. The regular uterus is seen superiorly of how they fuse together properly. We've seen this picture earlier. But if they don't fuse together in the caudal end, then you could have both a separation of the vaginal canal as well as an entire separation of the uterus, which is known as a double uterus and vagina, or uterus didelphus. Then you can have a less serious separation where the vagina is a single entity but the uterus is still bifurcated, and that would be the double uterus with a single vagina. The bicornate uterus is going to be the cervix, all the way to the cervix is being fused together, but then the body and the fundic regions are staying separated. And then if one side doesn't form at all, you can have a unicornate uterus. This will have no development of the ovary from connecting with the fallopian tube. Then you can have a septated uterus, which would be a fusion on the outside, but a loss of the cell death that would take the septum away from those two. So there's a few options. Incomplete fusion of the paramesonephric duct will give rise to those following possibilities, and we've just put them out in words here of what we just talked about in visual form prior. In the male genital tract, there's going to be some development that needs and requires hormonal influences. That means that the Y portion of the Y chromosome is going to be necessary to activate the production of androgens. And to do that, they start producing a special set of cells called the interstitial cells of Leydig. And around the 8th week, they're going to start to influence the production of the Wolffian duct system and take it over. Then there's going to be an MIF, or Mullerian inhibiting factor, sometimes known as anti-Mullerian hormone, because these are going to be secreted by the Sertoli cells from the primordial testis, and that's going to inhibit the production of the paramesonephric duct. MIF is going to cause the degeneration of that duct and therefore stop the progression of that default system to female. The testis, which is going to produce the testosterone from the interstitial cells and the Sertoli cells, will then start to produce testis, whereas the ovaries, the XX, is going to have an absence of testosterone and Mullerian inhibiting factor, and therefore the paramesonephric ducts will start to form. Now, let's talk about pregnancy for a few minutes. Of course, the pelvis and the abdomen could both be involved in pregnancy, and here you can see that miracle of life that is a little tiny foot poking through the abdominal wall. Of course, my wife, who I have 3 children with, loves the opportunity and that feeling of life growing inside of her, and I just think about the inability to pass that through my body. So I've decided that if I ever want the feeling of the miracle of life growing inside of me, I'm simply going to get a tapeworm. Because if you look at some of the effects of pregnancy, it's a little bit scary. The gestational diabetes, which will affect about 1 to 3% of all pregnant women, and usually develops in the 2nd trimester, and will oftentimes go away after the baby's born. The gestational hypertension, which would be high blood pressure, and the positioning of the uterus can have an effect on this, because the uterus, as the baby grows, will start to press against all of those great vessels inside the pelvis. Preeclampsia, which is typically a result of having a small, undersized placenta, and that can drive up blood pressure towards the mid to late pregnancy with the protein in the urine, and the only result of this is that you have to give birth, and that will resolve the preeclampsia, but it can oftentimes be premature birth for the baby. And then if there's chronic hypertension, which already exists prior to the pregnancy, that's going to be exacerbated and needs to be diagnosed before 20 weeks of pregnancy. And here is the magic transforming pumpkin of my wife, and you can see that I've painted on a pumpkin on her pregnant belly only a few hours before she gave birth to one of our little magic pumpkins, the smallest of them right here. It definitely is a miracle, and I feel very blessed that she likes to do it, because I certainly am glad I don't have to do it. Now, when there is a swollen abdomen, it could be the 5 F's that has a result of this, and you need to think about these 5 F's when you see swollen abdomen. Fat, flatulence, feces, fluid, or fetus. All of those could be the reason that there's a swollen abdomen. And, of course, you want to rule it out before you do any imaging, otherwise you'll end up with this kind of thing where you can see a little fetal head looking at you from inside this MRI. Now, an MRI is not going to hurt the fetus but a CT is definitely something you'd want to try to avoid if you have somebody that didn't know they're pregnant. That's a terrible way to try to figure it out. Now, when there is a swollen abdomen, it could be the 5 F's that has a result of this, and you need to think about these 5 F's when you see swollen abdomen. Fat, flatulence, feces, fluid, or fetus. All of those could be the reason that there's a swollen abdomen. And of course you want to rule it out before you do any imaging, otherwise you'll end up with this kind of thing where you can see a little fetal head looking at you from inside this MRI. Now an MRI is not going to hurt the fetus, but a CT is definitely something you'd want to try to avoid if you have somebody that didn't know they're pregnant. That's a terrible way to try to figure it out. Now we'll move on to childbirth and the labor. The actual birthing of the child, which is definitely going to hurt, has 3 basic stages. The first stage is going to happen when there's contractions that are building up gradually to open up the neck of the cervix. And that first stage is going to be consisting of early labor and then active labor as the transitional phase. Once you get into the second phase or stage, it's when you're going to start pushing against the fetus as you try to expel it from the vaginal canal. And then the third stage is going to be the delivery of the placenta itself, or the afterbirth. And in my opinion, they're all pretty terrible, but that's of course just one husband's opinion. What it means clinically is that during these stages, as there begins to be an effacement and a presentation of the fetal head, there's the potential that the reproductive system, the vaginal opening, could tear. And that uncontrolled tear can sometimes rip into the anal orifice, which can contaminate both the fetus as well as the wounds of the mother. Plus, it's much easier to sew up a cut than it is a tear, so the episiotomy is sometimes opted for if the baby is thought to be stretching the vaginal opening too much in order to prevent a tear through. With the male genital tract, you can see some of the remnants that we saw with the female genital tract. Now here there's going to be the mesonephric tubules that are going to be retained, and the efferent ductules will be incorporated into the testis, as you can see in section A. The mesonephric duct will also be retained and becoming the epididymis, the vas deferens, and the ejaculatory duct, as well as the seminal vesicle, which will be a diverticulum off of that. Once you get to the newborn stage, you can see that the mesonephric duct and the urogenital sinus are going to share some commonalities to it, more so than the female, and there's also going to be some potential remnants of the paramesonephric duct, which should be largely inhibited and is not as much of a problem for remnants as it is in the female system. But you can see that there's an inguinal canal. So there's a few remnants. Unlike the female, who has a Gartner's duct, there's going to be remnants in the male that will remain as appendicular vesiculoca, or the appendix of the epididymis. There may also be in the female an oophoron or paraoophoron, whereas in the male this will be a paraadidymis. That concludes section 35, where we've discussed the development of the female and male internal genital structures.